Good afternoon. It's a pleasure for me to talk in this teaching course about progressive multifocal leukoencephalopathy called PML. Shows you my conflicts of interest as usual. And if you go to the next, let me give you a historic walk through PML. It was first observed during naturally occurring hematological malignant disease and poor John Cunningham, which died from lymphoma. His brain got autopsied, and finally it was found out that he was infected by the so-called JC, John Cunningham virus. The problem with this virus is that it's ubiquitous, and as long as our immune system is active, we don't have any problems, and we don't have any animal model for the JC virus infection. We know that every one of us can increase the JC virus risk throughout life, roughly 0.5% increase in positivity. And for example, in Germany, it's around 60% of German people are infected with the JC virus. It's a slight dominance of males compared with females. And this is also representative in other areas of Europe. So with the lymphoma patients, the immune system is suppressed because there is a lot of lymphoma malignant cells which don't have a function. They suppress the healthy immune cells, and in most cases it's the lymphoma itself. There are some cases where the PML may be related to cytostatic oncotherapy, but this is rather the exception. Since we have been deep in PML treatment since 2008, I have at least 15 lymphoma PML patients referred to my department as well. And despite all the best care and medication which we did, the outcome is finally fatal unless the body by itself can control the cancer. And when you see Rituxan in lymphoma patients, then I would say that more than 90% of PML cases reported are due to lymphoma. Of course, there were traditionally some severe cytostatic oncotherapies which also shut down the immune system, and this may have also caused PML, but is getting rarer and rarer. You know that currently the treatment for tumors and metastasis is rather the checkpoint inhibition, meaning that the immune system is voluntarily activated and you rather have secondary autoimmunity and no other problems with these severe malignant disorders. Well, in the 1980s, the second big group of PML was discovered with the arrival of the HIV virus, and especially my friend Joe Berger, who worked in Miami for many years. He had a large HIV community and many patients dying from PML. Now, since we have triple heart, the highly active retroviral therapy, fortunately PML is getting more and more rare, and this is a good message. Now, finally, and this will be the focus of my talk, is the modern immunotherapy, multiple sclerosis, but also sarcoidosis. We have modern therapies. They are like game changers for highly active MS, but in turn, then PML may come since the immune system is severely downregulated. We will walk through the typical PML culprits. First of all, it's natalizumab, then we will go to fumarates, fingolimod, then frequent differential diagnosis to to multiple sclerosis, also sarcoidosis, neurosarcoidosis will show you some patients. Next, we have the spillover scenario, so meaning the PML is asymptomatic whilst patients who are receiving treatment, and then there is a change of medication because of high PML risk, and patients get symptomatic only with a new follow-up medication. And finally, because PML is often a differential, I will show you some highly active side effects which will occur with drugs where we have never seen PML so far in treatment of multiple sclerosis. I told you that natalizumab is a game changer. Well, with the pivotal studies published in 2005, 2006, and kind of surrogate of these studies, Eva Havredova, published around a decade ago, that we have 1 out of 3 patients completely free of disease activity, and this we call by now NIDA, no evidence of disease activity, meaning no relapses, no disability progression, and a stable MRI. This had never been seen before. What is the price of it? Well, you see that within the first year, but mostly after 2 years of infusion, the PML rate goes up, and this is from an early time when our worldwide cases were still limited. So nowadays, we have around 800 PML cases associated with natalizumab all over the world, but it has stayed constant that the risk really goes up after year 2, as you can see here, and it never comes down again. The longest natalizumab infusion patient which finally acquired PML had received 106 infusions. 106 infusions means at least 9 years of natalizumab, and she was pretty stable and really wanted to stay on treatment. That's, I would say, the fate of PML, and for these reasons, we have to be careful all the time when patients are on natalizumab. For reasons which we don't understand, and a colleague of mine, Robert Töppner, published his data some 6 years ago in JLP. When we have patients infused with natalizumab for more than 4 years, then you always have infratentorial lesions. Sometimes they may also be in the temporal lobe, as here, but as a rule of thumb, you usually have intertentorial lesions. Summarizing what we have learned from other PML-associated diseases, usually you only see the PML lesions in MRI in brain and brainstem. Usually you don't have PML infection in spinal cord and no spinal cord symptoms due to PML, but there are some patients where virus was post hoc identified on autopsy. So maybe the virus undergoes a mutation. Of course, the supplier of natalizumab, Biogen, did a very good job and tried to make a predictive assay established, and with this assay we could predict the anti-JCV antibody status. In the second version, which is called Stratified 2, we have this typical values which I walk through with you. If it's lower than 0.3, no index value, then as per 1,000 patients, usually you have a very low risk, something like negative patients, 1 to 10,000 to acquire PML. Then we have the gray zone below 0.9, and again here it's a rather low risk. It is between 1 out of 10,000 up to 1 out of 2,000. In my department, we still carry on these patients, yet I must clearly add that under ongoing natalizumab treatment you have a higher chance per se to acquire the virus, to get infected. So please repeat this test every 3 to 6 months. There is absolute gray zone when it gets around 1 to 1.5, and it's certainly a no-go when patients are higher than 1.5. Usually I stop them after 18 months. And clearly saying if the patient had prior immunosuppressive use, then they have double the risk. So there are scenarios where in year 2 patient has a PML risk of 1 to 100 if he or she wants to continue treatment. Personally, I clearly say this is not acceptable. So please shift. What can we do else? Well, retesting, of course, is mandatory. Every country has their own label. Well, usually when patients exceed 18 to 24 months, in Germany we recommend every 6 months, but in some susceptible patients I even go to 3 to 4 months testing with a stratified JC virus test. This is performed in a central European laboratory, the Unilabs at Copenhagen, and this is a very reliable test. In addition, it's not only what you see here, the anti-JCV testing, it's also the MRI testing. The MRI testing should also be done every 4 to 6 months. So now there is a continuous fight against this PML, not only by measuring the viral titers, but also by modifying the infusion interval. And Dr. Softis Ryerson and Dr. Fowley published this paper, and they wanted to study that if they extend the natalizumab infusion interval to 5 to 8 weeks, so meaning they let the immune system come back a little bit and get back a little bit of immunosurveillance of the brain, but yet not at risk of getting MS relapses. So that's a narrow edge where you're working at. And they wanted to determine whether this extended infusion interval, the EID, extended interval dosing, could reduce the risk of PML. It's a nice paper done retrospectively in 10,000 of patients in the TASABI observation program, and clearly looking here on the extended interval dosing and the standard interval, and you see that the PML risk screen goes down compared with the standard interval dosing by around 75%. This is encouraging, but we still need a prospective study, and this is currently running, to be sure how much we can reduce the risk of PML by extended interval dosing. Let me add another comment. We are no longer in the first decade of the century, we are at the end of the second decade, and we have alternatives in highly active MS. So you can do extended interval dosing in patients with a high titer, but this is not 100% sure that you don't get PML. Please give them informed consent about alternatives. You are responsible if the patient gets PML. It's not the company whatsoever. Can we do some supportive measures once the patient has PML? Well, if natalizumab has infused 4 to 6 weeks before, in this interval, I like to remove it by plasma exchange. And in Europe, we also can do immunoabsorption. Immunoabsorption is a medical procedure with a column, a tryptophan column, and it's not licensed in Northern America. Afterwards, patients improve immediately, and they are like honeymoon, and their typical cortical symptoms like visual field problems, slowing of cognition, affection of mood with depression or high irritability, they get better immediately. So this is a kind of honeymoon. And then the immune system gets access again to the brain and the immune system has to eliminate the virus. Otherwise, the virus will spread in the brain, will kill oligodendrocytes, and will do a lot of white matter destruction. So, no flushing back of the immune system, no elimination of the virus. But this flushing back, which is called iris, immune reactivity inflammatory syndrome, and this iris syndrome can lead to some collateral damage. After plasma exchange and when the diagnosis is made, I usually give mirtazapine as an adjunct treatment, starting with 15 mg in the evening and slowly increasing up to 60 mg if the patients don't get too sleepy. Also, I give a loading dose of mefloquine, 3 tablets per week, and then after there, only 1 tablet per week. In some very severe cases, you may do the old cytobovir, which came from HIV treatment, but be cautious, please. You have to do some protection of the kidney by doing infusions to get the kidney at a high filtration volume. The immune reconstitution inflammatory syndrome, iris, gets some inflammation. This is needed to kick out the virus of the immune system and of the central nervous system. But, and this is important, it's making additional damage. Therefore, you may consider to give steroids, for example, as pulses, 500 mg, 3 to 5 days, repeat a week after. And there are others which do a blockade with a chemokine receptor blocker, with a maraviroc, typically 2 times 300 milligrams. So limit iris, but do not completely suppress it because you need the iris. We at Bochum have experience with 45 natalizumab-associated PMLs, and of those, 3 patients could not eliminate the virus, and the virus stays in the brain lifelong. So this is, of course, a very bad condition, since MS usually comes back 9 to 12 months after PML, and it comes back severe if it was severe before. Now we have other oral treatments. They do not completely reach the efficacy of the monoclonal antibodies, but they are much better than the injectables of the last century. Let's start with the fumarates. Fumarates were introduced into the treatment of psoriasis, rather widespread skin disease in Europe. I think 1 or 2% of individuals suffer from psoriasis. And a biochemist and severely afflicted guy, Dr. Schweckendiek, he really discovered that fumarates are good against this psoriasis. And so this mixture called Fumaderm was introduced in Germany 35 years ago. Well, I saw my first fumarate-associated PML with this guy here. He has psoriasis for more than 20 years, and at age 70 it got more severe. So his dermatologist decided to start fumarate. And then he got hemiparesis on the right side, and he got this growing lesion, and as you can see in the center of the lesion, a biopsy was taken. And this biopsy finally was full of JC virus-infected cells, so the PML diagnosis was made, and the patient was sent to my department. Well, fumarate, of course, was stopped. It's very easy. Once you stop it, the next day it's out of the body. And we tried and reconstructed his blood values. And you can see that shortly before the PML was diagnosed, his values already went down around this time and was below 500. So be careful with fumarates. Your lymphocyte value should be above 500. Even more, I prefer lymphocytes above 800. Between 600 and 800 is a gray zone. And you know that they may change when you measure them every 4 weeks. It may go up and down, a natural variability. So personally, I would like only to accept low low-grade lymphopenia, grade 1. This is what happened for the first 4 cases of fumarate-associated PML. You see here the first case from October 2014, then we had more cases in 2015, and you see with all of them, these are the lymphocytes again, 500, the x-axis shows you the time scale. Here this patient was at least for 2 years under 500 until she got severe brainstem symptoms, and she's the only fatal case. Other patients also were below 500 for 2 years, whereas in others, only rarely measured, the lymphocytes were rather around 600. And this is what I tried to tell you. Please consider the gray zone between 600 and 800. I'm rather relaxed when it's 800 and higher. So, is this a big challenge? Well, we have to be sure and we have to be aware that when we use fumarates, it's easily tolerated in people below age 40, so we have only 1% lymphopenia. It's getting higher when people get especially above 50, and it may be 5% in patients of age 50 and older. And please keep in mind that multiple sclerosis is also unfolding after age 50. Times are getting different, we have more older patients. Natalizumab PML does not necessarily mean the end. 15-20% make a very good recovery and 30% only have mild symptoms left back. This is a case which I think is of interest. As a young woman, she was studying educational sciences, and she had highly active MS at age 28, and then she was put on natalizumab, and she had natalizumab PML. She did a nice recovery, fine recovery, and well, end of 2013 we talked about a new medication, and this was the time when DMF was introduced, and she took DMF, and she had scans every 6 months. She was stable on MRI, and her lymphocytes always remained high. Please remember, age about 30. She had some focal seizures due to PML, but the anti-epileptic drugs could be tapered off. Finally, again, she studied her studies as a school teacher again, and then she got into a confirmed pregnancy. She stopped immediately DMF, and her healthy first boy was delivered by cesarean section. Because of the focal epilepsy, I recommended her not to do a natural birth. So we published this case in March 2017. So altogether saying you can have almost normal life after PML, but the lethality rate in natalizumab PML is up to 30%, and some patients remain severely disabled. With the fumarates, we have around 400,000 patients worldwide taking fumarates for multiple sclerosis, and I think to my knowledge it's 8 patients with fumarate-associated PML, so this is 1 out of 50,000. This is, I think, acceptable, but I always warn to be careful with the lymphocytes. In dermatology, there is no good feeling. Probably there are some PMLs in the last decades, but there is no chance to open this black box. So, now let's go the sphingosine 1-phosphate receptor agonists, fingolimod, and now we have more and novel ones. Ponesimod will come, oceanimod has come, siponimod, clearly saying we only have data from fingolimod. And then I will show you a case of neurosarcoidosis, which got PML as well. Fingolimod, around some 4 years ago, we had worldwide 160,000 patients, 9 cases. So it's now around 20 cases with 250,000 patients treated with fingolimod. It's something like 1 to 10,000, 1 to 12,000 patients. The exception is Japan, They had around 5,000 finger limb-treated MS patients, so not the opticospinal form of MS in Japan, but the classical, I call it European MS, and they had 3 PML cases, and these cases were typically young people, and this was published by a Japanese colleague Nakahara, together with a colleague of mine, Ilya Eisenberg, in the N2 journal 2 years ago. And you can clearly see, when you read the cases, that they were young men, they didn't have a prominent lymphopenia, and they got PML. So finger limb may be less unpredictable than fumates when patients are really at risk. The typical finger limb PMLs in Germany are MS patients age over 60. So in Germany, these are older ones. Maybe it's immunogenetic, why we have younger patients. In Japan, all over the population of Japan, the JC virus persistence is more or less the same, like in Germany, no difference. So the next patient was an interesting one. He was referred to our department because this 38-year-old male had developed first symptoms of hemiparesis, and then they looked, he had no vascular or other risk factors, they looked screened him for some reasons, did the CSF, the cerebrospinal fluid tap, and they found JC virus. And finally, when we looked at him, at this patient, really progressive hemiparesis, so we treated him with mirtazapine, cytoprovir infusions. Finally, the diagnosis of sarcoidosis was only made by lavage. So by making the diagnosis of PML, the sarcoidosis could post-hoc be identified. Sarcoidosis is really, as you know, a chameleon, and be careful. I have another sarcoidosis PML patient who got steroids for 5 years and azathioprine for 2 years. He had persistent lymphopenia with lymphocytes under 300 per microliter, and we only got him stable when we did him on continuous low-dose IL-2 infusion, so it was 1 million IL-2 units every day subcutaneously, so that this patient could make a full recovery. Now, what is also a typical threatening is the spillover scenario. Patients are still asymptomatic whilst they get their old medication. Then the switch is made because of a risk of PML. Well, and finally, the PML unfolds. You see this woman, she had 2 years on natalizumab, she had a high JCV titer, she was switched, but at the time point of switching, no new MRI was done, no cerebrospinal fluid tap was done. She complained about dyslexia and slowing. She was sent to our department, and you see here this left occipitotemporal lesion, which is typical for PML. And at that time, remember, it was 3 months already after the last infusion of natalizumab. She already had spontaneous iris. So no need to eliminate natalizumab. The body had done its job already. We just gave her some low-dose steroids iris, and you can see that she made a rather fine recovery and could return to normal work. So be careful with the switch over, and natalizumab carry over to other medications is typically what we see. There were 8 cases which we reported for ocrelizumab with Roche and presented them as a poster at ECTRIMS last year. And by now, and I would like to add this, there's a single case of directly ocrelizumab associated PML in North America, around 70-year-old male, suffering from MS since 3 decades, having immunosenescence already, and after treatment with ocrelizumab, his lymphopenia finally made it easy for the JC virus to enter the brain and get him PML, which was unfortunately. So you now know the scenario of PML, but this is not all which is threatening. Just give you 2 quick shots on other serious side effects on modern immunotherapies, especially in multiple sclerosis. Taclizumab, which is a pan anti-CD52 killing agent, should reduce the MS for years when you have 2 years with 8 infusions altogether. And what this is a 40-year-old man, and he was referred to my department under alemtuzumab. You see his proton density scans here, and you see the gadolinium down here, and you can see it highly active, more than 50 lesions. And only when we did a plasma exchange and then introduced rituxan anti-B cell therapy, he got stable. So be also careful with others. And finally, this was a very promising agent because it activated NK cells, but at my colleagues at Essen, Dr. Kleinschnitz and colleagues, a fatal case with liver failure was observed in a young 26-year-old female, and you can see when they looked finally at the liver, you can see it was full of CD4 cells, CD8 cells, and also of NK cells. So this was the first major drawback of taclizumab, which looked very promising. And colleagues published severe eosinophilic meningoencephalitis with drug-related pathogenesis, so this is called DRESS, and of these 7 German patients receiving taclizumab and developing DRESS, 2 were fatal, and finally taclizumab was rejected from the market 2 years ago. It was such a promising agent, especially in unusual and progressive forms of MS. PML may occur naturally. I told you about hematological tumors. I told you about HIV before the typical triple heart treatment. And if it's with medication, it's clearly associated with adhesion molecule blockade, efgartigimod used for psoriasis, also at PML, such similar like natalizumab. I walked you through the modern orals with MS. And the PMLs, the risk is much, much lower than with the adhesion molecule blockade, but it gets really dangerous when the immune cells go down and when the immune cells go lymphopenia below 500 or with fingolimod typically below 250 to 300. So be careful, please. In other drugs, they can also represent a major challenge for treatment, but this is the modern time. Remember, the antibodies, they are really like targeted weapons, like a cruise missile, and they can really attack the immune system. Thank you for your attention, and I'm ready to take questions. Thank you again.
Thank you very much, Professor Gold, for this inspiring lecture and very also practical with also good examples from your own cases. And we already have accumulation of questions. So would you like me to read them for you?
Yeah, this would be kind, Letizia. Thank you.
Okay. There is a question on overall, which DMT would you choose for a patient after PML natalizumab associated?
Well, the DMT, which is necessary to control inflammation. We were very early to do a B-cell depletion when MS was severe, and the orals or the injectables did not suffice. So, as I showed you the cases, the orals like fumarate, fingolimod, they may work, but you have to be very careful with lymphopenia. If MS is not controlled with these oral medications, I would escalate and even use monoclonal antibodies. My preferred one is B-cell depletion, since the risk of B-cell depletion in PML in MS is minimal.
Thank you very much. So Maria Edvokia would be happy with your answer, very complete answer. There is Agan asking, regarding PML, you said that PML related to fumarate might be related to lymphopenia below 500, but the PML percent is very low in fingolimod, and most of our patients' lymphocyte count are below 500. So do you think there might be another mechanism for the occurrence of PML with fumarate?
Yeah.
Agan?
Very good question, completely agree. You know, in fumarate, the lymphocytes are pushed back into the immune organ, but they are more or less functional. In fumarate lymphopenia, the lymphocytes are killed by apoptosis and they are only partially functional. So it's a completely different mechanism. Therefore, I also am a little bit more careful when I have fingolimod in patients over 60 years. I also like to have higher lymphocyte counts when fingolimod recipients are above age 50, and you can now do the doses reducing by 50%, for example, by using the 0.2.5 mg dosage of fingolimod.
So in line with this question, can I add my own? So would you think the prognosis of a PML under fumarate or under fingolimod would be different?
Yeah, well, both of them. Yeah, both of them seem to have a very good prognosis, especially with the fumarate when it is really detected in time. The first patient who was treated at a major Hamburg hospital, not at the university hospital, but at a city hospital, she was detected much too late and had all types of infection and brainstem impairment via PML. So if fumarate is detected early, and if you have a watchful eye, it's not a major problem. And fingolimod, the only thing again is if people don't think about PML, continue fingo and continue assuming a relapse to get this. So usually fumarate and fingolimod have much better outcomes than natalizumab in PML situation.
That's very important. Thank you. I think Agan will be happy, and also myself. We have a question from Al Noor. How do you manage of lymphopenia of 0.2 on fingolimod? Patient is asymptomatic and the mass is controlled. So it seems an actual patient.
Yeah, very similar as I told before. There is not really a systematic control trial. How much lymphopenia is controlled in fingolimod? We have it since 10 years. So saying it, if it's a young patient, would be more relaxed. If the patient is getting age 50 and older, I would reduce the dosage to 0.25 mg to get a little bit less lymphopenia, either by prescribing the drug for juveniles, which is 0.25, or by giving the standard dosage every other day. Please keep in mind that the half-life of fingolimod is around 70 hours, so you can give it every other day.
Mm-hmm. There was initially a question by Enas. Can we give thrombolytic therapy in functional stroke presentation?
A thrombolytic therapy in MS? Yeah, sure.
In functional stroke presentation.
Well, if MS, you know that 10% of our MS patients are older than 60 and is getting more and more. And if these patients have a functional stroke, then of course you can do thrombolysis. I have no arguments against this.
Thank you very much. Oh, yeah, just Maria Advoca is very happy about your excellent presentation and for your answer to the question. So
thank you.
People are very happy, and myself as well.
Very kind of you. Thank you. It's a new feeling to be in a virtual meeting, but I'm glad that everything worked. Thank you.
Thank you. Then we will ask how many people are connected. So please feel free to ask questions, because there is also the possibility to answer later on.
We still have some time afterwards.
Yes. Yes, there is Edouard. Is the lumbar puncture for JCV PCR obligatory when switching natalizumab to another DMT?
It's not obligatory. When the patient is stable and a good neuroradiologist says there is a good MRI technique, so meaning you don't have 5 millimeter interslice distance, you see everything what happened, then you can just do a normal switch without lumbar puncture. However, when you want to get more than 95% certainty, this seems connected with our German genes. Many of us German people want to get more than 95% certainty. Then you do a lumbar tap with an atraumatic needle to be completely on the safe side. So if you do it on MRI, be sure that it's the MRI of very good quality and that you don't miss the lesion because there is a great interslice distance between the slices on the MRI.
So, Professor, may I ask you one question on my behalf? In patients who are JC positive, so you want to exclude natalizumab, do we have predictors of PML under alternative drugs so that we can choose according to the PML risk, or would you just ignore the risk of PML as lower and base your choice on other drugs, on other factors?
I must personally say, and I told you in the presentation, that in the first years when PML became a problem, we saw a lot of patients referred from outside to my department. And when I looked back, what I would have done, well, in most cases, it's not predictable when you should switch. After I have one patient who had more than 100 infusions until she developed PML. So usually, when it gets to patients which are already severely disabled, I select B-cell depletion because the PML risk for B-cell depletion in autoimmune diseases, not in lymphoma, saying it's around 1 to 20,000. And I also said that with Ocrevus we have very few. So I prefer B-cell depletion if it's very severe. If patients have only mild disability, then both S1P agonists and more will be available this year, and fumarate, both is possible.
Thank you. There is Isabella asking, we heard a lot of cases of PML with ocrelizumab now. Can you discuss it? Since the slide didn't show any case of ocrelizumab, how to handle it, how to use after ocrelizumab because of depletion?
Well, we summarized together with a committee of independent PML experienced people all the carryover cases of ocrelizumab, usually from lasolizumab and one from fingolimod. And this was on display at ECTRIMS 2019. Before Corona, this was still a normal live meeting. And well, the outcome was not too bad usually. Everything was done what is in the usual range to limit the virus, to block the 5-HT1A receptors via mirtazapine, and to use mefloquine. And if there was an iris, then you could think about Maraviroc. So there was nothing unusual which should be done, but most of the cases with ocrelizumab were indeed carryover ones. Unfortunately, there was one older American MS patient, age over 70, due to immunosenescence. MS was for 3 decades. He had never received any constant MS medication, only steroid pulses. And for some reasons, someone decided to start ocrelizumab, and he already had a high-grade lymphopenia due to immunosenescence and due to long-term MS, where the cytokines really influence the bone marrow. And this was the only intrinsic PML case with ocrelizumab. The case was unfortunately fatal. When we had a discussion under German MS neurologists, many of us doubted whether we would have chosen ocrelizumab after decades of MS. So clearly saying in it, the risk was mostly a carryover risk with ocrelizumab.
Thank you very much. Actually, Stefania missed the detail on your preferred number of lymphocytes under fumarate.
My preferred number is lymphopenia grade 1, which is something down to 800, a mild lymphopenia grade 1. I am aware that we have a gray zone. There are some cases, for example, the Department of Ludwig Kappos published patients who had around 650, 700 and got PML. So we don't know what is decisive in these patients. And I also warn, I know this from the follow-up, the so-called ENDOR study, there were some systematic lymphocyte tests done. If, for example, to Letizia or to me, a lymphocyte count would be done every other day, we would have a natural fluctuation of about at least 30%. So don't trust on a single lymphocyte value, but do it again maybe end of the week or next week to be sure that it's really not a day-to-day fluctuation, but really something you can trust on. But I like to have them above 800.
Okay, so something like a confirmed value.
Yeah, exactly.
Yeah, like for DSS. So Isabella is asking, she's the one asking you about ocrelizumab. And she's asking you what to use after ocrelizumab because of depletion.
Well, that is a very difficult question. There is, I mean, in these cases, it's typically a carryover situation. So, meaning the PML unfolded during ocrelizumab, but it was already there, but asymptomatic during natalizumab. Of course, I would not dare and use ocrelizumab again. First, check whether the virus could be eliminated. As I told you, 10% of our natalizumab PMLs still have the virus forever. They can't eliminate it. And if the virus is still in the body after this combo of natalizumab, ocrelizumab, it's only injectables which are allowed to be given, no orals and no stronger medication. If the virus is eliminated, I could, for example, consider that I use the oral with a reversible mode of activity, something like DMF, something like teriflunomide, but I would be careful about this.
Mm-hmm. So thank you very much.
You're welcome.
Thank you. So I leave the chairmanship to you now. Thank you so much for being with us.
Thank you, Letizia, and sorry again. Some technical problems. I only met 5 minutes later when the recording had already started. So it's a pleasure now to announce our next speaker in this selected circle. It's Magdalena Machak. And it's a very important question, as we recognized in the last 3 months. It's infection and vaccination in MS. All of us are aware of the worldwide corona pandemic. I'm sure Magdalena will tackle this. And of course, also the point of vaccination, when and how can it be done. Please go ahead.